I'm always shocked at how many physicians have never done orthopedic ultrasound exams.
If you get it into the joint, whatever you're injecting is probably going to spread through the whole joint. But there are certain times when our classically taught techniques aren't going to work. Since 2008, all the PRP I've given is 100% been activated.
I just wanted to welcome everybody, and we're going to keep this pretty informal. And basically, this is going to be an Ask Don Buford anything or burning questions that I want to know about. So I'm going to ask him. But ultimately, this is this time frame where I'm like, gosh, where are we in regenerative medicine? And the top three things I want to know is, what about ultrasound, guys? Is it precision or is it overhype, right? I think we all know the answer, but I wanted to dive into that a little bit. Can we still, at this time, be okay with not using ultrasound guidance? And then I think the thing that I have as a question is standardization of PRP. Like, how do we achieve consensus? How is it that we go about being really thoughtful and smart and being able to all speak the same language? And then the one that I'm really excited to delve into is, what is the future of orthobiologics? And we'll go into that a little bit more, but let's get started. And I'm going to just make sure everybody is here. And we're going to be admitting a couple more people and we'll go from there. Okay, so Don, tell me, I still get every day, I still get people who say, well, I don't need ultrasound because I know where the joint is. And in this day and age, I really have, this is how we were all trained. This is how we were taught. First of all, what do you tell them?
Well, all of us that have come through orthopedic training are taught manual palpation, bony landmarks, what the joints look like, what types of joints there are. And so, certainly on a basic science and basic anatomy level, we do know where the joints are. That's not controversial. For that matter, we should also know where the nerves and arteries are too, right? The issue is really that having a way to be more accurate should always be better. And I don't think that should be a controversial statement. I haven't found anyone yet from any specialty who's 100% accurate injecting everywhere. It just can't be done. There's one paper that's been published years past where it was a cadaver-based study with residents and attendings doing injections into the subacromial space, and the misses ranged from being subcutaneous to intra-articular or intratendinous. And so, the bottom line is we have an imaging modality that has multiple benefits. One of them happens to be that it makes you a better injectionist, if you want to use that word, because you can see the needle going into the body. And it's really not more complicated than that.
So, so the argument is don't you want to be more precise? I guess is the argument that you have. Yes, is that correct?
Yeah, and even in those situations where, if you get it into the joint, whatever you're injecting is probably going to spread through the whole joint. But there are certain times when our classically taught techniques aren't going to work. In fact, I had two people today in the office that I would have struggled and turned them, unfortunately, into a pincushion unless I got super lucky to inject their knee because there weren't bony landmarks like you would expect. And so if your patient population is not 100%, 5'9", average male, 160 pounds, or 5'5", average 120-pound woman, then there's going to be times when you're going to wish you had something besides just your fingers to feel the anatomy.
Gotcha. Well, yeah, thank you so much. I always struggle with that conversation. Like, yes, we know where the joint is, but, if we have a modality, I think it is a better
Yeah.
way to see. It's like being able to see through skin and bone and muscle and know exactly where we're going. So when we talk about PRP, I know, and then we don't have to ask for directions or fumble around in the dark. So when we're talking about PRP, I think there's been a lot of conversation about trying to characterize it. And I think we're still kind of currently talking about, oh, this leukocyte rich versus leukocyte poor. Do you think that there is a more nuanced way to think about it? Is there should we be talking about it differently? What are your thoughts on that kind of discussion of classifying it in these two different camps?
Yeah, I still think in this discipline, we're still at a stage where we need to continue to collect all the data, because we don't really know, when it's all said and done, what the magic numbers and what the magic characterization is going to be to match and correlate with clinical outcomes. Now, there's the obvious things, leukocyte rich, you've already named leukocyte rich, leukocyte poor. I like adding a leukocyte neutral category. There's other things.
Can you explain that a little bit? And there may be people on this call that don't really understand how you can have a leukocyte neutral. Like, what does that mean?
So traditionally, in years past, leukocyte rich PRP typically referred to PRP where the white blood cell count was north of in the 20s, 25, 35, somewhere in that range. And when you got into WBC counts that were that high, a lot of us noticed that patients seem to have more trouble with pain and discomfort around the time of the procedure. Their outcomes may be the same. In fact, a lot of recent data is showing that their ultimate outcomes may match even leukocyte poor, but the issue was around the time of the injection for some of us. But that's with a white blood cell count well above the upper limit of normal human WBC count, which is maybe, we'll call it 10 or 11, okay, on a typical hematology machine. Leukocyte neutral, what I call leukocyte neutral, and I don't think I'm the first, would be a clinical example where I get a CBC on a patient, their white blood cell count is 5, which is well within the normal range. We make the PRP, and their white blood cell count in the PRP comes back at 7 or 8. It's a little bit higher than 5, but it's still within the normal human range up to 11. So I tend to call that leukocyte neutral because at that level, it doesn't seem to create any flare, even though if you're going by the strict semantic, criteria of, is this number higher than that number? Sure, 7's more than 5, but 7 is still within the normal human range. So that's what I would consider leukocyte neutral. Leukocyte poor would just be starting at 5, and in your PRP, you're less than where you started.
Now, here's the more burning question is, should we be talking and should we be thinking about which leukocytes? Is that too broad of a category?
At this stage, it is. I mean, it's going to take, honestly, probably a lot of computing power to correlate specific leukocytes. And, you get into even things like eosinophils and basophils and all the things we used to learn in hematology class to try and correlate that to clinical outcome. Right now, I think the best thing we have that's kind of easiest to access would be the platelet number and the platelet dose. It's easier to structure clinical outcome studies around platelet dosing right now. And of course you can correlate leukocyte content, but even with that, we can still see variations in outcome and variations in outcomes amongst different researchers. So I think it's going to take organizations like the Biologic Association, which has their tremendous BARB repository project, where they're storing and quantifying basically anything you can quantify coming out of blood. And then at some point, that's going to go into a big supercomputer, in my mind, and some AI is going to figure out the charts and the graphs and see if they can do a regression and figure out what's correlated to what.
Gotcha. So is this part of the standardization process? Like, how do we standardize? Because currently humans are very variable. And in the morning, my blood content is different than in the afternoon. And, maybe my platelet count is 200 and yours is 400. Like, how does that significant variability play into this standardization?
Yeah, I mean, I can tell you how I approach that. That's a really good question because that is basically where we're at every day clinically. How do you decide how much blood to draw? How do you decide, what dose? And for me, in my practice, I simply try and match what I think is the highest level evidence for the clinical indication that I'm looking at with a particular patient. And that comes down at this point, in my opinion, to platelet dosing, which is simply volume times platelet concentration. And you have to have a hematology machine to really know that. So that's why we have a hematology machine. That's why a lot of people on this phone call or on this webinar have a hematology machine, so we can track our dosing. In order to do that properly, and because I don't often have a starting platelet count, and because it can vary, I've geared my clinical practice towards assuming that everybody is at the lowest end of normal. And so I'll say that again. I've geared my clinical practice with PRP towards assuming that everybody walks in with a platelet count of 150, which is the lower end of normal. And based on that, the one variable I can really control in the office that day is the amount of blood I draw. And so if I assume, and I can control my protocol and my centrifuge times and which kit I use. So if I know I have a B plus to A plus kit, one of the better kits, whether it's 2-spin or single spin, and I assume the starting platelet count is 150, then that tells me how much blood I probably need to draw to get to a certain dose. And that's the one variable I can control. Once I have that butterfly needle in, truth be told, the answer is often 120 cc's. There's somewhere between 60 and 120. And because the kits tend to come in 60, or 120, or there's one kit that starts at 80, which is a nice feature. But for most of the time, I'd rather be a little bit too high, meaning I'm drawing 120 for a lot of these clinical indications, even though the end volume of PRP may be relatively low depending on where I'm using it. At this stage, I'd rather be too high than too low, because I think I'll catch more people and get a better clinical outcome for more people if I'm a little bit on the high side in terms of dosing, as opposed to being a little bit on the low side.
Gotcha. And then, there has been some conversations about the fact that monocytes are super important as an immune modulator for these treatments. So what are your thoughts on the fact that we do think about that and we know about that? And then for a long period of time, we used primarily what we would call leukocyte poor, and we excluded those monocytes, yet we still had reasonable outcomes. So I don't know. Like, is it the resident monocytes that we care about, and we're affecting change at the resident monocyte, like the in-tissue monocytes? That's why we care about them, or do we want to bring more monocytes in? Like, I actually don't know this. This is why I'm asking.
Well, and those are all good questions, and those may be hard, if not impossible, without some really slick studies to answer those questions. And I'm like you, at the end of it all, the one result I want to see in the conclusion is this patient had this dose or this treatment and was better for this many months or years. And then I want to match that protocol. Now, if that includes a discussion about monocytes, fantastic. Tell me how you did it. But right now, with the best outcomes we have, it seems to be more tied to blood draw volume, PRP dose. And whether those platelets are being activated, endogenously, which is, I don't activate my PRP, about to start a study with that, which we'll talk about, but I don't activate the PRP. I let the collagen and the natural tissues activate it for me, which happens pretty quickly anyway. And when that happens, whether that now creates this paracrine effect that you're hinting at and activates the monocytes, then that may be what's happening. There may be many different pathways to get this common result. So it may be something where at the end of it all, as long as we either put in a high enough dose to do it in-house, or we give them a drug exogenously to create the same effect, ultimately we're getting the same biological, endpoint.
Great. Now, you did hint at this activation, if you will, and there's some other really smart people that I've been talking with in the field, and there's this discussion about should we be activating our platelet-rich plasma? What are your perspectives on that? We don't, some of us, around the world are always activating. Some of us are never activating. Probably the answer is somewhere in the middle. But what do you think about that?
I've never, I mean, since 2008, I've never activated, at least not outside the body. So let me say that a different way. Since 2008, all the PRP I've given is 100% been activated. It's just all been activated after I inject it.
Nice.
None of the PRP I've injected has been unactivated. Okay.
Yes, of
All been
course.
activated. So the question is, do you do it 2 minutes before or wait 4 or 5 minutes after? And there's some recent studies that show a difference in not only the immediate, granule release from the platelets, but also over the next 4 or 5 days, there's some differences. And so there may be some difference there that's important scientifically, but it all comes back to this, Ariana. It comes back to the fact that the studies that I think are the best for knee-OA didn't activate exogenously. The studies that I think are the best for lateral epicondylopathy, lateral epicondylitis, the ones that I think are really good didn't use activated PRP. Now, that doesn't mean there may not be a good study with activated PRP that showed that it was successful as well, and that's great. I would just match that protocol. But I haven't seen anything that's significantly better in the activated PRP world that changes that for me.
Is there any place where you would say, gosh, I really want to think about activating PRP to try to have it stay in one spot or whatever? Is there any application where you're like, you know what, we may be onto something for this?
Some of our surgeon colleagues have been doing that for almost as long as I've been in practice, trying to use a fibrin clot for meniscal repairs and sewing that in various ways, and that makes sense. But I'll tell you, I think I'd have to check the registry, but I just from experience and anecdotally over the last long years, 5 to 10 years, just by injecting my PRP at a high dose at the meniscocapsular junction, I think I'm getting the same outcome with my meniscal repairs as if I were injecting, or tying in a fibrin clot. And that's a bit of extra work, as you know, that's not always easy to do when you've got a tough meniscus to repair. So I prefer injecting at the meniscocapsular junction. So there may be places though where you want to create an activated version of PRP so that it stays put, or so that you can manipulate it in a way that it's got more substance and structure to it.
Sure. Awesome. Okay, so now for the hard questions.
Oh, hey, that wasn't the hard ones? Oh no.
Yeah, so there's been a lot of discussions about the future of orthobiologics, autologous orthobiologics, and there's been a lot of companies that are looking for the holy grail of injection in a bottle. Number one, how close do you think those companies are? And then number two, does that make you nervous for the future of autologous therapy?
I don't know. I'm not real up to speed on things outside the country. I know they're ahead of us in terms of already having some off-the-shelf stem cell products, mesenchymal stem cell products in other countries that we don't have the opportunity to take advantage of in this country. But I have no doubt that at some point there will be kind of an allograft PRP version. And if the dosing's controlled and we have good dosing, clinical protocols, that may be the answer. I always worry, obviously, about something that's now allograft, where you have to worry about a few other things. It's left someone else's body. It's been processed in some lab and stored in some lab and then shipped to the doctor. So we always have to worry about all those intervening steps, which is why the FDA still considers that making a drug, because I think it is making a drug. But there's lots of drugs on the market. Making a drug by itself shouldn't scare us and shouldn't scare the companies. The question is, it's a tremendous financial investment. And at least in the United States, the financial investment also includes a tremendous regulatory overhang. And that's what's really slowed down development, in my opinion, in this country. So our answer may very well come from overseas. And then, wouldn't it be neat if the FDA would accept some of the preliminary early studies from other countries to fast track things into this country that are biologics? So we'll see what happens. But For me, it's all about the end of the line. What's the clinical result and what's the easiest, cheapest, safest, fastest way to get a patient there. So maybe not by the end of my practice career, but by the end of some people on the call, there'll be something allograft like that where we won't even have to draw blood.
Yeah, yeah, absolutely. Well, this has been great. I think I have a final question, and then I'm going to turn it over to our audience because now this is a very lovely, intimate setting where honestly, how lucky are we that we get to sit with you and just pick your brain? I have about like 100 more questions. So if nobody like puts them in the chat, I'm just going to start like with my 100 question list. So, but we'll give everybody a chance. But I did want to like ask one last question about ultrasound guidance, ultrasound training. Like, I feel like that's one of the biggest hurdles for widespread adoption. And I just wanted to pick your brain on, and how is it? What do you think is going to be that stepwise adoption, like where it's, well, of course we use a stethoscope to listen to the heart. Like we don't put our ear on the chest, right? Of course we use an ultrasound to look at musculoskeletal stuff.
Yeah.
Like, like why is there such a disparity? Because like in the rest of the specialties, ultrasound, like in emergency medicine, ultrasound is common and standard in looking at lots of things. Why, number one, why is it like such a hurdle? And then what's it going to take to have widespread adoption in our musculoskeletal education system?
The hurdle part's a tough one, right? Because MSK sonography has been around for long enough for that to have been exposed, for people to have been exposed to it. I think like anything else, it starts at the training level, but probably even before the residency level, so even before you hit an orthopedic-based residency, hopefully the medical schools, and I know this for a fact that there's many medical schools now that are using ultrasound in their gross anatomy courses, and I think that's fantastic because that's where you start. And I think the rise of some of these portable, handheld, wired or wireless transducers that connect to an iPhone or any phone or your computer or tablet and make this modality more accessible and more cost effective for schools and training institutions to have them for their students, I think that'll just help. Just getting introduced to it, that's kind of your gateway modality, your gateway transducer, if you want to call it. Maybe something small and portable, but as you get better at it, you start to learn that there's higher powered devices maybe. So I think at the training level, that's really where it starts. We're coming at it from both directions, right? Because we've got some very high level clinicians in various specialties that are very, very good at sonography, and they're teaching kind of from the top down at a lot of high level international and national meetings. And then from the bottom up, it's starting at the medical school level also. And with residencies and fellowships, filling in where they have appropriate faculty to teach. So I think we'll get there. It's clearly way better than it was 16, 17 years ago when we started our course. I mean, it's night and day improved. It's basically in every orthopedic meeting, there's lectures and talks about sonography. If you look in almost every, or just say the top 10 orthopedic journals, not only are there articles that include orthobiologics in every edition, which I think is fantastic, but there's also articles that will include sonography if it's appropriate, either for diagnostic or outcome measures, things like that. So we'll get there.
How long do you think it's going to take before it's standard, like using a stethoscope to listen to a heart?
Well, gosh, it's only been 16 years since we got, probably another 15 or 16 years.
Okay.
It's going to be a minute.
Okay. All right.
Because you have to realize everybody that's in practice now, if they want to be cutting edge, I think they have to learn how to do it. And you have to get past the mindset that using ultrasound is a sign of weakness when it's obviously not. It's actually quite the opposite. It makes you a much better clinician. And none of us get ultrasound because we're scared that we can't inject the knee or the shoulder. We get ultrasound because we want to know exactly what we're doing and be able to do it better, And so that mindset really starts in training when you have no preconceived ideas and there's no, call it ego or whatever attached to what you're using. You're just a student learning everything there is out there and having that open mind back then. And so I think when that next generation of orthopedic clinicians comes through that are, just now coming out of medical school, but they've been in a program where they had ultrasound all the way through gross anatomy and what have you. I think those people will be even better than we are, with the transducer. They'll have grown up with it, and they'll be even more expert at anatomy, because it's really just applied anatomy.
Right, right, absolutely. All right, so I'm going to open this up. Thank you so much for spending your time and really pontificating about, all the things that we care so much. So we have some questions here, and you can choose not to answer, or if you don't want to. So the question is do you find that cervical facet PRP injection under fluoroscopy is safe, or would you recommend against it and recommend platelet lysate instead? And then there's just some discussions about volume and, for example, how much do you draw if you're going to be using 1 cc per facet?
So right out of the gate, I have to stay in my lane, because I do some lumbar spine things under ultrasound. I don't do any fluoroscopy, and if I was going to be up around the cervical, I think fluoroscopy is still the gold standard. So I would say that is safe. I think fluoroscopy is safe. I think that's the way, again, the gold standard. You can do some things with ultrasound. We could all get on YouTube right now and type in ultrasound-guided cervical facet injection. There's going to be some very high-level videos showing how to do that, but recognize that those people are experts. And like anything else, if you're going to do that, you want to get some good training to do it. In terms of volume, I can just correlate that to other areas in the body where we inject 1 cc. Like maybe I did a carpal metacarpal joint today, base of the thumb. At our course we just had, we injected the great toe MTP joint, which is a low volume. And in those low volume injection situations, I typically draw, honestly, I typically draw 60. 60 is kind of my ante to get in. But when you concentrate down to 1 cc, if we can't find anything else to inject, it's obviously going to be very highly concentrated. You may have platelet counts in the 3,800 range for that 1 cc, so you're putting in 3.8 billion platelets in 1 cc. But just know that can be done. I just, again, if I'm going to draw and concentrate down that much, I still want to have a high enough dose that it makes sense.
Sure. We have a note from Alan Mishra. Thanks, Dr. Buford. I've been teaching ultrasound to the Stanford ortho residents and sports fellows for many years. They love it. And, Alan says he thinks it should be a part of every training program. And, I 100% agree. And I'm always shocked at how many physicians who come from really great programs across the board have never done orthopedic ultrasound exams or injection-based therapies, or, maybe they've done like 2, but it's not standard of care.
Yeah, and I love that. I mean, those of you that don't know Dr. Mishra, he's one of the original gangsters in this gang, right? And the fact that Dr. Mishra takes this time to do that is what we all need to do whenever. I mean, that's just my bias, but I think we all need to do that. And so that's why we have a course. That's why we have seminars. That's why we try and reach out to whoever wants to learn. We try not to be really, our courses aren't just for orthopedic surgeons. They aren't just for doctors. We cover anyone that wants to learn this imaging modality. And I think it can only help all of us. So kudos to Dr. Mishra too.
Yeah, he also says your course is amazing, and I'm gonna second that, because that's where I learned. I was fresh out in brand new resident and fellow right out of sports medicine fellowship, and I had no idea. I'd never used an ultrasound in my entire training, and so I went through your course, and I was like, oh my gosh, and my eyes were open. I was like, you can see so much. It's great. No more guessing. So there was a question, with all the recent flurry of papers, do you have a minimal total platelet amount per joint? And then what happens if you don't reach that threshold? What do you do?
So that's a great question. And the short answer is yes, I have an idea in mind. What I'd like to do for soft tissue applications is get above 3.5 billion platelets. And remember that the dose is volume times concentration. So you could do that with 3 cc's at 11 or 1200 platelet count, or you could do that with 1 cc and a platelet count of 3500. But that's based on some work that was spearheaded by Dr. Peter Everts and others in a collaborative kind of multi-center trial, where the soft tissue papers, looking at PRP outcomes, the soft tissue papers that had doses under 3.5 billion, 14 out of 14 had outcomes that were not statistically significant. And if you go above 3.5 billion in a single injection for soft tissue applications, and this was a summary of all the different ones that are out there, from tennis elbow to Achilles to rotator cuff. If you were above 3.5 billion, 9 out of 11 papers showed statistically significant outcomes. The disparity between that number, obviously 3.5 billion is arbitrary, but using that as a cutoff, the disparity between papers below that dose and papers above that dose was unexpected and striking. It wasn't just a gentle curve. It was like horrible, horrible, good, good. Okay. And so for soft tissue, I want to get above 3.5 billion. For joints, it's a little bit different. And let me back up and say one more thing. There's some independent research just for rotator cuff that suggests you want to get to 5 billion or even higher. Okay. And back to that initial conversation, if you have somebody with the lowest normal platelet count of 150 and you draw 60 cc's of blood with a reasonable machine, you ought to be able to get to 5 billion platelets for most soft tissue applications. Inside the joint, a lot of people talk about Bansal's paper out of India that has a dose of 10 billion platelets for a knee. Fewer people are familiar with Chu's study, which is a 3-injection protocol, 1 injection a week, and weekly the dose was 4.2 or 4.3 billion, don't quote me. But the total dose after 3 weeks was 12 billion, pretty close to Dr. Bansal's 10 billion. So question is, what do you do if you make a PRP injection, it comes in at 7 billion and you're planning on doing a single injection? I've found that they do okay. If I'm close, I would hesitate. And again, that's partly because we're drawing so much blood. Now, remember what I said also, because I don't want to be in that situation as much as I can avoid it. I often will draw 100, often, if not always, will draw 120 cc's, because then even if they're at 150 platelet count, if you do that math, we are starting at such a high initial platelet volume, 18 to 20 billion platelets, that even with a mid-level PRP making protocol, we're still going to end up at 10 billion. Even if we lose 50% of the platelets in the process of making PRP, we're still going to end up around 10 billion, if that's your target. If I really thought 10 billion was my target and I only ended up at 5 or 6, yeah, I would probably go back and draw more blood, to be honest. But that hasn't been a concern. I don't think we're fine-tuned and sophisticated enough to say 9 billion is not going to get the same result as 10 billion. I think there's a margin of error there.
Yeah, absolutely. Now we have a question. This is a question that comes up very, very often, and it has to do with local anesthetics.
Mm-hmm.
And she says, I read that Xylocaine 2% doesn't negatively affect the platelet, and it's okay to use to numb the surface of the tendon, for example, in lateral epicondylitis. Do you agree? And then how do you control pain during the procedure?
So I don't necessarily agree, but I don't know everything. It's just my opinion. And so as a result, I don't use lidocaine, xylocaine, bupivacaine, any of the canes when I'm doing a lateral epicondylitis injection, because it's just too close. I don't want to do anything that could potentially have a negative impact on my procedure. And so the second part of her question is really the key, because it's the same question I had when I said, okay, if I can't use lidocaine, and I'm not going to do a general anesthetic, there's got to be something in between. And the answer for me, and for most of us, I use a lot of ethyl chloride. Okay. And I can often use a 25 gauge needle for lateral epicondylitis. And then the key for me is I also can concentrate the volume down. So patients' pain for these relatively superficial soft tissue injections or for small joint injections is directly related to volume, in addition to some other things, other technique items, but the volume makes a big difference. And so, many, many, many years ago, and it'd be great to have Dr. Mishra's opinion on this, but many, many, many years ago, I would inject 3 cc's and kind of flood the zone for lateral epicondylitis. With ultrasound, I can be much more precise. I can target that hypoechoic defect. I can needle a couple times, and I can put in 1.5 cc's, get the same clinical outcome based on my registry, and far less pain.
Great.
And then use ice after. I haven't found ice to be a negative thing to use after. That comes up also. So we use ice after.
Yeah. Perfect. Awesome. Thank you so much. I think this is another really great question. What sites or specific journals are your favorite? What do you go to for the latest studies and articles on orthobiologics and regenerative medicine? I think that's a really great question, because there is a burgeoning amount of data coming out, and it's really hard to wrap your mind around and wrap your arms around the sheer volume. And if you're just getting into the game, it's like, how do you figure out where the right stuff is?
And it's hard because although there's journals out there, like I'm co-editor with Alan, Dr. Mishra, and Bill Merle on a journal that's orthobiologics specific, but good papers come from all over the place nowadays. And so you're exactly right. So just having a subscription to one or two isn't enough. And by the same token, you don't want to have to buy every single article for $25 or $45. And so what I do is I've set up some search parameters on Google. So this is a hot practical tip. I've set up some search parameters on Google, and particularly on Google Scholar, for any paper that has particular words in the title or in the keywords. And the obvious things: regenerative medicine, orthobiologics, PRP, leukocyte-rich PRP, just anything you can think of, you can create a search criteria on it. And I have it set up to just email me weekly with any new articles that meet that criteria. Sometimes the list can be pretty darn long, but you can wade through them. I also try and limit what I do. Where I start is with the human outcome studies, because those are the ones that may have a chance to initially impact my practice the quickest. And then I'll backtrack and look at animal studies and basic science things just because they're interesting to me. But beyond the journals that are part of my specialty, so the orthopedic journals that have specific orthobiologics content, to capture everything else that happens across the planet, I think you have to use search parameters. And now with ChatGPT, I'm kind of interested to see if there's a way to use that just to create some search, kind of robots that go through, and as things get published, if they have the keywords that you're looking for, it emails you.
Brilliant. I'm sure we're going to find a bot really, really soon to to get that. Yeah. Oh, Atiba says there is a way, Dawn. There is a way. So we'll be working on that bot for everybody. Oh, he's already working on it. So when I say we, I mean somebody else is going to be working on that, and hopefully we'll get that in everybody's hands soon. Sure. Awesome. Well, hopefully this has been very helpful for everybody. I really appreciate the opportunity to be a part of this, and I'm so glad that everyone's taken time out of their day. I just wanted to share a couple of things, and so I'm just going to share my screen. We have questions, right? And our slideshow is going to be basically this. We'll just do this. Okay. I'm sure this is not exactly right, but we'll just go ahead. And I wanted to this is the conversations in regenerative medicine. And I really appreciate everyone being here. I started this series because I really wanted to pick everybody's brain, and I didn't know a better way. So if I'm going to do it, I'm going to share all of the answers with my friends and my colleagues, and really put it out there, because this is an exciting field. Obviously, we know who I am. I'm an orthopedic surgeon, and been working with interventional orthobiologics, and I'm obsessed with helping doctors to add orthobiologics to their practice. So we had a lot of great questions. I really appreciate everybody really joining in and asking those hard questions, and not being afraid to ask those questions that we all are wondering about. After this, you will receive an email for an opportunity for the PRP Power Play. And so integrating strategies on how you can add or improve your offerings for your patients and really deliver results and grow your practice in a meaningful way for both your patients and for practitioners. If you want to continue the conversation, we are continuing this conversation. Next week, we'll have Dr. John Farrell. We'll have Dr. Mary Ombach. Hopefully, Dr. Alan Mishra will join us. I'd be honored. So if you want to scan that QR code, we do have that available. And then we just want to bring to your attention, if anyone's going to IOF Max in February for any reason, Phoenix, Arizona, one of the best best annual events, IOF, Interventional Orthobiologics Foundation. I'm going to be bringing you a day of business. So you're bridging that gap between your skills and your knowledge, and turn your expertise into a thriving practice that you absolutely adore. And then anytime that happens, we have some other opportunities, but we also have a BA Summit. So save the date if you're interested in the BA Summit, May 7th. Yes, it's in the middle of the week. Yes, it's going to be amazing. So definitely save the date. And then finally, we have Women in Orthobiologics and Wellness. And I'm here to help. I have a newsletter that discusses how you can take these research papers and apply them to your practice. How do you talk to your patients? How do you use all this data that Don just spewed out from all of these different studies? And how do you actually use this to help guide your patients in whether they should be choosing other, PRP? What should I do? And how can we guide our patients using the best, newest, latest research? So I just wanted to bring that to your attention. But I'm so thankful that we are able to be here and have the ability to host Dr. Don Buford. Thank you so much for your time. If there's any other questions, let's see here. Great. Yes. Looking forward to seeing you both at Biologics. Thanks, Dr. Mishra. Thank you all for joining us. I really appreciate it. We're going to wrap this up, and we will see you next week, hopefully, with Dr. John Farrell. Keep your eyes peeled for that, and please let me know if I can help you. Thanks so much for coming. I appreciate you all.
Thank you all. Bye-bye.